So I'm Vicky Enne. I'm a microbiologist based at UCL, and I'm the program manager for Inhale. Here are my conflicts of interest. So what is Inhale? So I'm pleased that many people have mentioned it already today. So we are an NIHR-funded research program, and our overall aim is to improve antimicrobial stewardship through implementing molecular diagnostics for HAP and VAP in the ICU setting. It's very much a pragmatic, real-world design. So we've been all throughout, we've taken all comers because we want the results to be applicable to clinical practice in the UK. We also wanted to represent as diverse a case mix as possible. 15 ICUs took part in our sort of lab evaluation of how well the test performed, and 14 took part in our RCT. We had a good mix there of tertiary referral centres, district journals, paediatric centres, and one private hospital, and all our different hospitals are shown on this map here. And the recruitment for the RCT spanned from July 2019 to August 2021. So we had both the pre-pandemic era and then during the pandemic as our recruitment period. The programme as a whole, so as I said, it's all about implementing molecular diagnostics for HAP and VAP. We started off with diagnostic evaluation, so lab evaluation of performance of a variety of tests. We paired that along with observational epidemiological studies and sort of patient characteristic studies at 4 of our centres. We then chose the test that performed best in the lab evaluation and took that through to the RCT, which is what I'm mainly going to be talking about today. Alongside that, throughout the whole, which is now a 7-year programme, started off as 5, but we're on to 7 years now. We've had a behavioural study, which Rob is going to talk about after me. We also had some health economic analysis. So in our pre-study, we compared 3 tests, essentially: the Coritis pneumonia test, the FilmArray pneumonia panel, and we had some nanopore technologies, metagenomic sequencing. While that was really interesting, we didn't put it through the whole evaluation and consider it seriously for the trial, because it's still, I think, too preliminary, and it requires at this point in time a lot of hands-on work, which wasn't suitable for what we wanted to do. One thing that came across really strongly from our early results, and I think a lot of people have alluded to this already, is number 1, PCR is much more sensitive than culture. Another point, which I think has been touched on by various things people have said, but no one stated it outright, is that there's a lot of variability in the way different people do culture. So this is, in the orange bars, we have culture positivity per site, so any pathogen found at our different sites in the Work Package 1 study, so 15 sites. So Site A had a 30% rate of culture positivity. Site O had 85% rate. And the blue bars show the PCR, and as you can see, there is variability, site-specific variability in the PCR results, but it's much, much less pronounced than the culture variability. And we looked at various reasons why that might be, and we did some additional culturing of our own, and we looked at various statistics. And the conclusion we came to is that it's mainly driven by subjectivity. So I think what Michael was saying earlier, where he works, they don't disregard gram negatives from CAT patients. And a lot of different laboratories and hospitals across the UK have different conventions in how they interpret results. So some places take everything from a respiratory culture from ICU and report it. And other places weed out a lot more. So is differences in how people interpret them, and that's partly driven by the fact that we don't have a lot of BALs being taken, there are very few, and there are no guidelines provided on interpretation of sputum samples or endotracheal aspirates. If you read the guidelines, there's lots of guidance on how to culture them, but it says nothing about how to interpret them. They said there's no evidence. So we know that culture isn't ideal. So knowing this, when we looked at our laboratory evaluation, we didn't want to use the culture as the gold standard, so our statisticians instead came up with a clever Bayesian modelling. I'm not going to pretend I know how that worked, but essentially what they did is they took all our available results, did some modelling of what was likely the true results, and then calculated the sensitivity and specificity of each analyte. And if you do that, you can see that culture really had appalling sensitivity for all of the main pneumonia bacteria. And this was from 630 samples from 15 different centres, a large study. Whereas both the film array and the curetis had excellent sensitivity and specificity. So they were both good candidates for us to take through into our trial. So then it came down to other characteristics, and we compared the two in terms of time taken, size, how users liked it, factors to do with storage of consumables, etc. And essentially the film array did perform better on all of these characteristics, so we chose to take it forward into our RCT. Originally, we were going to be putting it in the laboratory, but during our clinical evaluation study, it became abundantly clear that there was going to be a lot of time delay associated with it. A lot of microbiology laboratories were also very reluctant to run a new test just for research purposes, whereas on the other hand, all the ICU clinicians were really chomping at the bit to have it. So we made the decision to put the torch at the point of care in our ICUs, and here's a picture of a nurse using it at UCH ICU, and there's a patient just over here, so it was really in the centre of all the action. And in our study, we took patients with suspected HAP or VAP, so they had to have been in hospital for more than 48 hours, and they had to have been about to receive an antibiotic to either treat a new HAP or VAP or a worsening HAP or VAP. Our target was 552 patients. We then randomised. Control arm got standard of care, and the treatment arm got the film array run at the point of care, along with some optional prescribing advice, which was delivered to the treating clinician. This is a picture of it. It's quite complex. It stretches to several pages. This is the first page. We unfortunately couldn't work out how to make it simpler than this, because you have to account for multiple pathogens, resistance markers, whether there's allergy or not. So, but this was optional. What I think I would say is, according to what Tristan said, is some of those choices that were given in one of Tristan's last slides, we would have advised against, because generally we felt that any antibiotic against the species where resistance is generally 10 to 15% nationally was probably not a safe choice in ICU. So things like coamoxiclav wasn't recommended for E. coli unless there was evidence for it. Right, so the primary outcomes were non-inferiority of clinical cure at 14 days post-randomization, and a superiority outcome of improvement in antimicrobial stewardship at 24 hours post-randomization. And this was measured as patients on active proportional antibiotics. So active, I think you all know what that means. It's active against the pathogen found, and that was either by film array or by culture, and every single participant in the study had both. So the film array, the samples were frozen and ran centrally at a later date, but the results were available for the decision making. Proportionate, we essentially mean the narrowest reasonable antibiotic that patient could have been given. So if somebody was getting meropenem for Haemophilus, that would be active, but it would not be proportionate. Over here, our protocol's been published with the full details if anyone's more interested. These are some of our secondary outcomes. So they were basically divided into various additional antibiotic outcomes and clinical outcomes. One thing that was quite a challenge was deciding on the activity and proportionality for all our results. And as advised by our NIHR-appointed steering committee, we had an independent microbiology committee, which consisted of 3 independent senior microbiology consultants and David Livermore, who's our co-chief investigator. And they met regularly by teleconference and in person to look at all the stewardship outcomes. This wasn't a small task because each patient took about 10 minutes minimum, and there were 558 of them. The outcomes were based on case reports. Importantly, the committee was blinded both to the study arm, because the film array was done in both studies, so they couldn't tell by that, and also to the eventual patient outcomes. So our antibiotic outcomes went up to 72 hours, so they weren't given more data than that. We had a proportionate was adjudicated by a further person as quality control, and there were some ground rules, such as inactive antibiotics couldn't be proportionate. Anything that was given on our algorithm, so we had a master algorithm and some local adaptations, had to be automatically accepted as active and proportionate unless there was, say, culture susceptibility testing evidence to say that the bug was resistant. If susceptibility data was not available, we used local and national surveillance results. And if the patient was completely negative, so no pathogen found by any method, then the judgment was based on the clinical condition of the patient. So, if they had high infection markers and they were doing very badly, as Vanya would say, they were trying to die on you, then our committee would consider it reasonable to continue that person on broad spectrum antibiotics. Whereas if there was someone doing relatively well, improving, then that would not be the case. And here's just an example of the reports at the committees. Also, we have a graphic of what antibiotics are given and when, some basic demographics, infection markers on day 1, essentially the SOFA scoring for day 1, and then the culture and the film array results. So this is our participant flow. I think the only thing I'm going to say about this is we recruited 558 patients, and we were very fortunate that we lost very few of them to follow up. These are our baseline characteristics. So I'd say this is almost identical to Tristan's, which is reassuring. So they were mainly male, medium age of around 60 years. The children had a median age of 2 years, and overall about 70% of the participants were children. There were no discernible differences on the other characteristics. In terms of comorbidities, again, it would be very much what you would expect, and the balance between the arms was very good. The main point to note is about a third of our patients overall had COVID-19 at recruitment, and this was equal in both arms. So on to our results. So the stewardship outcome, so this was participants on active proportionate antibiotics at 24 hours. In the control arm, this was 55.9% at 24 hours, rising to 76.5% in the intervention arm. So we had a roughly 20% increase of patients on active and proportionate antibiotics. I think this compares favourably to most stewardship interventions of different types, whether it be behavioural, PCT, etc., and it was highly significant. So that was great news. However, our clinical cure, our control arm had a clinical cure of 64.7%, but our intervention arm only had a clinical cure of 55.9%, so it was slightly lower. The difference was 6% as calculated by our statisticians. This was not clinically significant, but crucially our non-inferiority margin of 13% was not met because the confidence interval is 15%. So what we would conclude from this is the clinical cure is inconclusive at this point, and we probably need more data to understand it better. Looking at some of our secondary outcomes, so the antibiotic stewardship outcomes, so if we break our different outcomes down at 24 and 72 hours, people on active antibiotics, active and proportionate antibiotics 72 and active antibiotics 72 hours, then in all of those cases, the intervention arm is doing significantly better than the control arm. We had relatively low proportions of narrow spectrum antibiotic usage throughout, and that's probably because this was a very sick cohort of patients. But again, the intervention arm did moderately better, although that was not statistically significant. Looking at clinical outcomes, for most of these are equal between the two arms, so mortality, ventilator-free days was 2 days or 11 days versus 9 days for survivors. Length of stay was 11 days for intervention, 13 days for control, or 14 days in both arms for survivors. So there was no difference between the two arms. There were 2 outcomes where we did see a difference, but both were quite low numbers. So we had more antibiotic-associated diarrhea in the intervention arm and more secondary pneumonia in the control arm. But on the whole, other clinical outcomes apart from the clinical cure are equal between the two arms. One of the big secondaries we looked at was SOFA score. So those of you that don't work in ICU might not be familiar with SOFA. It's basically a measure of the organ dysfunction of the patient that predicts mortality and looks at various physiological parameters for different organ systems. Our baseline SOFA was around 7 in both arms. So the higher the SOFA, the worse it is. So if you have a SOFA of 24, you're essentially dead, and if you have 0, then there's nothing wrong with you. At 7 days, it had gone down to around 6, and at 14 days, it was 5.4 in both arms. The secondary outcome that I was looking at was change in SOFA score between baseline and day 7 or baseline and day 14. And again, there was no statistically significant difference between the arms, particularly if you adjust for confounders such as COVID and bloodstream infection at recruitment. This first one is just nudging on significance, but once you adjust it, then it's no longer significant. So we were quite perplexed, I think, to be honest, because we had a good result on the antibiotic stewardship. We saw big improvement at 24 hours, and that continued at 72 hours, but we did not meet the non-inferiority margin. So we've done some exploratory analysis to try and understand that better. So I'm just going to share a couple of these. So the first of these was clinical cure by stewardship group. So this is quite a complicated slide, but here we have whether or not there was a pathogen found by any method. So first 3 are negative, there's no pathogen found. And then the bottom 3 are there was at least one pathogen found by at least one method. And these bottom ones are quite low numbers, so you can't read a lot into them. These ones here are equal between the arms, but when we look at this last category here, so it's people that had a pathogen found, where the committee judged them to be on active and proportionate therapy, so good antibiotic therapy, and we found that the control arm had a cure rate of 75%, whereas the intervention arm had a cure rate of 58%. So this group of people that have a pathogen found and have active and proportionate therapy are the ones that are driving this difference in clinical cure. So it almost doesn't make any biological sense. I haven't got the data, but we have started looking at algorithm adherence, and we know that people that adhere to our algorithm generally did better, but adherence was low, so we're very relieved that we weren't driving worse outcomes, but still doesn't explain why. Another thing we looked at was potential in subjectivity. So this shows clinical cure by site. So we can see that there are a few outlying sites where the difference in clinical cure between arms is more pronounced than others. And this is a moderately significant degree of heterogeneity, and that may come down to the fact that clinical cure is very, very subjective. And in hindsight, it may not have been the best outcome to pick, but it's the one that is used in most of the big trials for new antibiotics for pneumonia, so that's why we chose it. So to conclude, there were significant improvements in antibiotic stewardship achieved in the intervention arm compared to control arm, both at 24 and 72 hours. But the equivalence of clinical cure was not demonstrated at 14 days. Other clinical measures such as mortality, length of stay, ventilator-free days, and SOFA showed no significant difference between the arms. And the difference in clinical cure occurred mainly in the patient group judged to receive active and proportionate treatment and had no pathogen found. And we're now looking at further analyses like looking at exactly what antibiotics they had, looking at exactly what pathogens they had to try and understand this clinical cure result better, but it may come down to having to do a second study. So yeah, just I want to thank everyone, all the sites, all the site PIs, research nurses, laboratory staff. Inhale's a huge effort. Our funder, NIHR, Biomeria, generously donated the machines and tests, and the study team led by our two co-CIs, Vanya and David Livermore.